Good afternoon. My name is Linda Protopopis, and I'm the Executive Vice President of Sales for HealthRecon Connect. Good afternoon and good morning to the webinar that we are offering on maximizing your laboratory revenue. I'd like to introduce William Baus, who is going to be our speaker for today's webinar. William is our Director of Laboratory Service Support at HealthRecon. Just to give you a little overview about William, William has over 15 years in healthcare revenue cycle management. His last decade has been entirely focused on laboratory revenue cycle management, building onshore, offshore, and hybrid teams to satisfy the needs of his clients. William has worked inside laboratories, the Internal Revenue Director, with preview over every step of the revenue cycle process, as well as managing RCM vendors. William is tirelessly focused on compliantly maximizing the revenue for laboratories, whether that is through the adoption of technology, application of deep state knowledge of payer and national coding policies, or providing access to relationships that can change bottom line for labs. As a reminder to all of the attendees on this webinar, if you have any questions at all, please feel free to raise your hand or fill in the chat box, and I'll call on you at any time. We do want this to be, an open forum, so please, you don't have to wait till the end. I will then call on you, and then William can answer any questions that you may have. At the end of the webinar, please feel free to fill out the survey so we know a little bit more of some of the topics that you're looking for. Within the next few days or next week, we will be sending an email out to all of the attendees with a copy of the slide deck, as well as the recording of this video. Thank you so much. And William, it's all up to you, sir.
Thank you, Linda.
You're welcome.
Thank you, everyone, for attending. As always, anything that I'm talking about that sounds like I'm talking about a lawyer or I'm offering legal advice, we're not doing that. We're not offering coding advice. Everything you do should be reviewed by certified professionals in their various areas. That being said, welcome, maximizing your laboratory revenue cycle. So this 4-part series and everything, there's a whole bunch of front work before we start getting into little specific things that labs can do to help their in-house billing department or their outsourced billing department, which we would love to be a part of. So how will you go about acquiring referring physicians? It's if you were doing COVID and you were working, the tents and things like that, you might not have been aware of some of the ways to get access to referring physicians. And then really, in my viewpoint on what has been successful for labs in the past is to know who your referring physicians are and then do the testing that they want. Seems obvious, but sometimes we start off with buying a machine and looking at what the most profitable test that there is. But for longevity in the market, the labs that have done well at this are usually not one-trick ponies where they only do one type of testing and only have one type of payer that really sets you up for any change in your environment, really having a big impact on your income, and usually that's not positive. So then you look at, after you know what they want, what can you perform, and then what is the payer mix of your referring physicians, and what does it mean, and how does that impact you? We're going to be discussing. And then we're going to look at what testing is out there that you can be paid for. And then relationships with other labs, I think, is something often overlooked and can be very beneficial to your lab. So we'll be discussing all of that. So how will you go about acquiring referring physicians? Expand or use your existing physician relationships. It's very common for the owners of laboratories to come from different directions. You may be a laboratory that is being run by or owned by a sales group. And if you are, well, then you already have your referring physicians, and that's great. You might be more of a clinically oriented lab, and your technology is fantastic, and the testing and the turnaround time and everything that you can do in your lab can be very good. But if you don't get yourself out there and promote yourself, then referring physicians don't know about you. And so depending on somewhere in between those two spectrums where you are, networking events and conferences and local medical societies, educational programs and seminars that you can put on about the uniqueness of your testing and how it can be applied to a specific physician specialty, for example, can be a good way to advertise yourself to physicians. And a lot of times I do see that labs that have longevity are labs that have promoted those relationships directly with the leadership of the laboratory. So that's a very good way to expand or acquire additional physicians. You may be interested in buying a lab, and that's a good thing to do if you're looking to acquire a physician base pretty quickly, assuming that they've maintained it and done a good job with them. It's also another reason to buy a lab is because of their grandfathered in-network contracts. This can be very difficult for you to get in-network contracts, and those are usually the two reasons I'll see somebody look at purchasing a lab. And it's really important, though, to do your due diligence. I mean, if all you're thinking about doing with a lab is buying their assets, or you want to get started with your lab a lot quicker, somebody might buy a lab that already has their CLIA and their COLA, which will save you 60 to 90 days, and maybe already has their Medicare number and the home state Medicaid, which is, it's nice, and that'll save you 60, 90, maybe even longer, depending on if you don't do those things quickly or correctly. That can save you a lot of time, but you will then potentially have the any problems that have accrued for that lab. And so, some things you might want to consider when you look at doing a due diligence are, looking at the corporate and organizational structure, so you understand all the components that are that lab that you are buying and what are all of the issues you have to deal with. Like, they've got to have leases, and do they really have an active CLIA or not? And all these kind of things need to be looked at. So you look at facilities, you look at the commercial matters, you look at the legal proceedings and compliance, and if you're not asking these questions, it's not necessarily the same as it is for buying a house where they have to tell you some of this stuff. So it's really good for you to ask these questions and find out if they've actually had a suspension, maybe. So if their Medicare number is suspended, it's not a death sentence for buying a lab, but it can definitely, it can cause you a surprise if you're thinking you're going to bill a lot of Medicare claims and then you can't. So you want to take a look at all of that, then your licensure, your certificates, CLIA, your COLA, your CAP, and how those relate to your in-network and contracts with HMOs and MCOs and commercials and your federal contracts. And then, I have even noticed sometimes where, maybe you're not buying a lab and then you're going to put your own people in. So if you're not putting your own people in, you don't need to worry about the management and employee matters. But if you're also going to inherit a team of people that are working the lab, then you do need to find out about what those contracts are with them, and anything that might actually be potential conflicts of interest, and your information that you have that you're going to be adding into this team that might be deciding to leave later to go start their own lab again, right? So you kind of want to make sure you check all that out. Then, of course, you'll have financial and tax matters. So you're going to need like a CFO to be looking at those elements. And then, of course, you'll want somebody that's versed in looking at your reimbursement and your billing collections. And that's definitely something we could help you out with at HealthRecon. Is we can definitely focus in on the billing aspects, review your contracts with your payers, make sure they're still current and active, and what the implications are. A number of times we've reviewed lab contracts where a lab mentions that they're in network with everybody, and that's usually a clue to me that they're probably talking about multi-plan, which isn't really being in network with everybody, and that's a whole deep conversation on its own. But due diligence is key. You don't want to buy something that you're going to end up having to do a recoupment payment for in the millions, and so checking all of that out is going to be really helpful to you. The other thing you could do, and what I highly recommend being done, as opposed to not having a direct relationship with your sales force, such as maybe using a marketing arm, which if you use marketing, you really need to pay attention to anything that involves telemedicine. And I don't mean telemedicine done properly is quite okay to do. What I do mean, though, is if the acquisition of samples are coming from something like a Dr. Chase program, or, and when I say Dr. Chase, there are different elements of that, and typically that's considered a bad word. When you look at current indictments, for example, they'll use words like that. And so what they're talking about there is advertising directly to a patient, and then sending and the patient then indicates that they'd like to do that test, and then that marketing company sends your requisition pretty much all filled out, and then the doctor signs off on it. Those are usually not good. And, marketing companies that buy lists of Medicare numbers and start promoting your services directly to patients can also be very problematic as well. You would definitely want anything like that looked at very heavily by legal and compliance team. But building your own sales force is always a good way to go, and it's safe and you control it. When you work with outside independent sales reps, for example, you will then become somewhat dependent on them for your volume to be maintained. And if they decide to leave, that can be very quickly detrimental to the lab. So hiring and training your own sales force, making sure that they're aware of the relevant laws and what they do, it gives you a lot more control over it. And there are even companies, there's one called the Core Academy, Blake Burke. He can help you identify and find the right fit of a sales rep, but there are other companies as well, I'm sure, out there that do that. It just happens to be one that I know and I'm familiar with and does a good job. So when you're hiring marketing consultants, things that you want to be aware of are ECRA, and ECRA kind of, let's see, okay, good. Yay, it's coming up. So you can find stuff online everywhere that will talk to you about ECRA and this law and what it means. But effectively, it's something that makes sure that you don't pay based on sample volume. And so there are different ways to compliantly remunerate people for helping you identify samples. But you also have state laws, and ECRA is a federal law. There are certain safe harbors, as you can see, kind of looking at some of this real quick. I mean, this isn't intended to be an entire discussion of what ECRA is and how it's there. The biggest thing you need to know is you can't pay people based on volume, right? But you can pay them fair market value, which is another term that comes up a lot when you think about marketing contracts, which should be done by not the lawyers that are involved, but an independent auditor type company that can come up with what fair market value is for the exact services that are being provided. But that's something that you should definitely be looking at if you're going to be hiring marketing consultants, and even your internal W-2 employees. You have to look at how you're compensating them against that as well. Again, like I was saying before, you definitely want to be aware of these telemarketing companies and making sure that you've got brick and mortar orders from referring physicians that are going to have relationships with late relationships with their patients, and that they're going to use your results to treat that patient. And so, running tests that you don't know what the clinical utility of those tests are, even though we say, well, we're the lab, we're not the clinician, we're not the doctor, so we don't have to be worried about medical necessity. Well, it's kind of not true anymore. It's becoming more and more evident, more and more clear that Medicare and other payers expect the laboratories to educate the ordering clinicians on what has medical necessity according to the payers and what doesn't. And of course, we can't tell a doctor how to practice medicine, but at the end of the day, you, the lab, are the one that's going to be holding the bag when a payer decides that the tests were not medically necessary. They don't go to the doctor and get the money back because they didn't pay the doctor, they paid you. So they're going to go back to you to take that money back. Here's a relevant recent OIG issue. This is a pretty good website to go through if you're wondering about a particular arrangement that you're considering with a marketer or with your own sales reps or relationships that you'd like to develop with your referring physicians. The OIG does a pretty good job, the Department of Justice does a pretty good job of putting these things out here. And so $463 million in genetic testing. And let's see, I wanted you to just see that they actually mention Dr. Chase in here. And now I think where's find. Okay. It's in here somewhere, but the idea that I'm just putting out here is when you see that they're performing sophisticated genetic tests, this is what a lot of our labs are interested in doing because they reimburse very well. But patient brokers, okay, that's the word that they use for this a lot too. But as soon as you start talking about telemedicine companies or patient brokering, you start getting into hearing about kickbacks to telemedicine companies. This is something that's really coming up a lot, and you want to be very careful about acquiring samples that way. And then again, the way that you can pay marketing individuals is through fair market value arrangements, not based on volume for the services that they provide. Definitely check with your lawyer on that. I'm not a lawyer, nor am I trying to provide you with legal advice. I'm trying to provide you that you do need to be aware of these laws out there. Other legal considerations you would have when you're working with referring physicians may seem pretty obvious, but you can't pay them anything or give them anything of value to receive orders from them. You'll have state level laws about this. You'll have federal level laws about this. If you happen to be a physician that owns a lab, you have different operating rules of what you can and can't do. In general, you could say this: if you're a physician-owned lab, there's a boon to that because you'll be able to extend your in-network contracts that you already have to your own lab. But you'll have a restriction of that you can only use your own patients. And you would also be restricted from referencing a sample out to another lab that will perform the test and then you billing for that test. It's a peculiar thing for a physician-owned lab, but essentially when you read through the documentation about this, you'll notice that what the payers are concerned about is when you have your own lab, then everybody starts getting this test. That's a really expensive test. You want to be careful that you make sure that there's medical necessity for the ordering of your test as dictated by the payers in those situations, and that you're using those results to treat your patient. And that the payer actually thinks there is utility for these treatments that you provide to the patients. So the next thing that you do once you've identified your physicians is you're going to want to make sure that you provide the testing that they want or accommodate them. An example might be a primary care physician. They're going to maybe want blood chemistry and maybe infectious disease testing like respiratory pathogen panels and gastro panels or STI panels. And whereas an OBGYN, they might be doing the blood chemistry tests, but they might also want to do non-invasive prenatal testing, maybe some UTIs, maybe some STIs. So you're going to have different ordering patterns coming from different types of specialists. Kind of obvious, but if you end up focusing on just working with OBGYNs, you can really dial into what they want. They're even going to know what their standard tests are based on what period of pregnancy a woman might be in. And so you could even kind of guess what the volume of those orders are going to be by just looking at their patient mix, right? So things to kind of talk about with your physicians are, well, what labs do they currently work with, and how many relationships do they want to have? A lot of times, a good way to penetrate the market with referring physicians is by having blood. It's typically not going to be very well reimbursed. Medicare is usually like your best payer for blood, particularly because you don't have the deductible or co-insurance with Medicare as you do with a commercial payer. And we'll get into discussing some of those things to think about from a payer perspective in a minute. But, if they want to work with only one lab, then you might really need to look at, well, what testing are you being able to offer? And maybe you want to incorporate doing blood to support their blood requirements, or having a really good partner lab that you can then get the blood to in time, or even divert the sample at the point of origin. How many labs do they order from? What do they order? Get a list of what their current requisitions look like. Get a list of what they're not getting as well is important. And sometimes that's an educational process with your sales reps to them. And then looking at the volume of those tests will help you kind of make sure you're ready to support them. And do they want to consolidate their ordering? So if they may be working with multiple labs, you might be able to tell them that while you can't necessarily run everything, you could make sure that all the samples come to you, and then you make sure that those samples go to the right labs for the ordering, or for the satisfying their ordering requirements. So then you would want to look at what testing can your lab actually perform, and then maybe do you need to expand what those elements are. So, chemistry, your basic chemistry blood tests, the hematology tests for, RBCs and platelets and all of that. Very basic test ordered by most doctors that are primary care physicians. And then even other specialists will need to be looking at those. It's almost our go-to stuff. They will order those all the time. Microbiology seems to have not fallen out of favor, but it seems to be difficult to actually create a microbiology section. And given that, there are 27 states right now in the MolDX Medicare Administrative Contractor regions, you're not really able to get paid for the PCR infectious disease testing. But microbiology is the go-to. I mean, all the payers really want you to be testing for most infectious disease with cultures. And we know all of the arguments about how, well, it takes 3 to 5 days. And sometimes you can't even culture certain things. And if there's contamination, you got to start over again. So the utility of that seems to be pretty low, but you do have a lot of, well, all payers are happy to pay for microbiology infectious disease testing. Not all of them are happy to pay for it when performed on a PCR platform. And I'll spend some time talking about that when we get into some of the, what can you be reimbursed for different kinds of testing sections. Immunology and serology, the antibody levels. This is still blood, and we're talking about allergy as well again here. There's a lot of the general practitioners do like to do allergy testing. So it is something to look at. It's not a real high dollar value item, but it can definitely supplement what you're doing already if you've already got a core blood lab. Molecular diagnostics. Okay, so this one's a fun one because this is where all the new stuff is happening. And I also see people throw around the term and talk about it as if everybody thinks molecular diagnostics is the same thing, and it's not. But it's predominantly related to looking at the DNA or the RNA of, well, either something in the human body or the pathogens inside the body. And for us right now, it's predominantly going to be the infectious disease testing, whereas in, say, a Novitas or First Coast or National Government Services, those locations do not utilize the MolDX program. And so they are currently still paying for PCR testing for respiratory pathogens, gastropathogens, UTI, nail, wound, dermatology, ophthalmology, skin, joint, bone, whatever place you're collecting it from. The way that you bill these things are as individual pathogens. So as far as a payer is concerned, these aren't really different panels. They don't really have different codes for them, except for a few of them, like respiratory pathogens have their bundled codes, and gastro pathogens have their bundled codes. And there is a women's health panel, but it's actually a multi-analyte algorithmic analysis code, which means there's an algorithm that you have to run in that. But for the other elements, like a UTI, a nail, or a wound, well, there is no bundled code. And so as far as a payer is concerned, when they just look at the CPT codes, they can't tell that that's a UTI versus a wound. Because many of the pathogens you're billing, you don't even have a specific code to even tell them what pathogen it is you're testing. So they don't really know what it is that you're billing when you're billing that. They just know you're billing for a bunch of detection of infectious pathogens. Now, the really good thing, or the new thing, is, next generation sequencing. I do get asked a lot to explain what's next, what's the new thing, what can I do to, increase our income and serve our patients better. Well, the new thing that's been here for a while already is next generation sequencing. And there's somewhat of a little bit of an issue with it. So, of course, everything that we just talked about here, if you happen to be in a MolDX MAC, Noridian, WPS, CGS, or Palmetto, if you're in any of those MACs, you're going to need to have a Z code and a technical assessment. So the whole question of coding goes out the window, because they're going to tell you what code to use, and it's probably going to be an 81479. Or if you're doing something like a cancer test, there's probably already a GSP code for that already. And it's very difficult to get through your technical assessment, particularly around clinical utility, when you're trying to get a Z code and a technical assessment. And let me take a moment there just to describe this, because I think there's another thing that confuses people a lot about Z codes, and that is, so you fill out your application to get a Z code, and then they come back and say, great, your Z code is active. And then at that moment in time, it's very confusing, because it sounds like, okay, good, I got my Z code. That's what everybody says, I need a Z code, and it's active, so I'm good to go. Well, no, that's not the case. That's because once you do your Z code and turn that in, you're supposed to turn in your technical assessment, of which there will be many. Depending on exactly the type of test that you're doing, you'll have a different technical assessment, which is typically comprised of three things: analytical validity, clinical validity, and clinical utility. And it is the clinical utility section that is preventing us from getting a covered Z code for something like a UTI. Pretty much anything that doesn't already have its own bundled code is going to be very difficult for you to get past, because you can kind of inherently see that they have not agreed on medical necessity for the test, because there aren't linkages between the CPT code that you use and diagnostic codes. Once I see that there's a CPT code for something and there's diagnostic codes for something, well, then we can kind of infer they already know there's medical necessity, AKA the indications, AKA the diagnostic code. So if somebody has these diagnostic codes, they're telling you, then they're going to cover you performing that service. So for something like a UTI, a nail, or a wound, there isn't any of that. So you can kind of guess that, well, we've got a problem with clinical utility. And when you kind of dig into that a little deeper in a conversation with MolDX, you'll find out that, well, there's a 9-page list of all of the clinical trials that they've reviewed that they're still stating do not support medical necessity. And it basically centers around they're concerned that people might end up treating for an infectious agent that isn't causing the infection, because PCR is so sensitive. It maybe will pick up a pathogen that is dead. And so now you're telling somebody that there's a pathogen that you've detected that they need to treat, but it wasn't even actually creating the infection. So that's all going to get worked out eventually. People are performing clinical trials as we speak now. And as soon as that comes out, within weeks, Thermo Fisher is going to know about it, and then everybody who uses Thermo Fisher is going to know about it, and then everybody else is going to know about it. And so you would be able to then perhaps reference that clinical trial as being clinical utility, and presuming that you used the same technology and methodology, then that would probably work for you. But right now, it still has not happened yet, as far as I know. And I checked again a couple of weeks ago, and I still couldn't find anybody that had a UTI, a nail, or a wound. In fact, the only thing I've been able to identify is some STIs that have gotten it. I don't even know anybody that's gotten their respiratory pathogen panel or their gastro panel done. Although there is a way, there's a back door to all of that, which is if you use an FDA-approved test and you use it in the ways consistent with the instructions for use, and you only perform one FDA test and you haven't modified it in any way, well, then you don't need a Z code in a technical assessment. So just to loop back on that whole Z code scenario, is your Z code will become active pretty much after 15 days. And if you filled out their 36 questions correctly, you're going to have a Z code and it'll be active. And if you didn't, they'd tell you that, hey, this wasn't right or that wasn't right. And you go back and fix it. Well, the next step is doing your technical assessment. And until your technical assessment is successfully passed and you've satisfied all the requirements, your Z code is not covered. But that may take you several months to do. And if it does, that's why they gave you an active Z code that has an active date, which really is more like an effective date. But what that means is, let's say your Z code was active in January and it takes you until October to pass your technical assessment. You could go all the way back, at least for Medicare claims, because you get a year. You could go all the way back to January and now bill it with your Z code because it was active as of that date of service of January 1st, let's say. Now, people really always want to talk about what is the new thing, and the new thing is NGS testing, but it's not getting done appropriately in all scenarios. So 27 states, it's kind of a moot point about knowing anything about whether they pay with a certain code or not, because they're going to tell you what code it is. And in a lot of instances, if it's a new kind of test that hasn't existed before, they're going to give you an unlisted code, and then they're going to tell you the price that they're going to pay for it if you do actually pass it. But then there are 3 other Medicare administrative contractors that don't use the Z code program. And in such instances, you want to really be connected to the dot of my doctors that are ordering it. Are they qualified to order it? And are they the right doctor for treating the patient for that condition? And it might be a little questionable, for example, that a primary care physician would order, let's say, a neurology panel that discusses mutations in genes and treatment protocols for a patient that they're not equipped to actually treat the patient with. So you want to make sure you have the doctors ordering it, they understand what the results are, and that those results will actually be used to make a change in treatment for the patient. And it was interesting to me because I had recently worked with a provider, Dr. Ruben Guerrero, and I had asked him to take a look at an immunology panel that a lab that I was working with was running. And they were running a it was an immunology panel. And that immunology panel included genes in it that, didn't have any relationship to any immunological disorders. And so I then said, hey, maybe we should take a look at this. And we did. And what we found out was kind of a roadmap to being able to test the right material for the right indications. And so you would want to do something to develop the assay that you're actually running. And you'd want to make sure that the genes that you're looking at have a relationship to the disease phenotype. And in some instances for cancer or other hereditary diseases, there are things like ClinGen, which is the Clinical Genome Resource, or the Memorial Sloan Kettering Cancer Oncology Knowledge Base, which is OncoKB, or the NIH, the National Institute of Health. So they've already done that work for you. They've already said these genes with these mutations have these relationships to disease phenotypes. And then they even connect that to primary diagnostic codes, as well as taking a look at what your symptomatic diagnostic codes might be for the ordering process. And so you would want to make sure that you developed your assay content, and you could develop the assay and still not necessarily run that in-house and have another lab run that for you. Or you could bring that in-house and acquire the instrumentations and set up the methodology and do your own validations as well, but those are fairly expensive. I mean, from my perspective, if it was my lab, I probably wouldn't spend $500,000 or $1 million on a next generation sequencer without knowing that I had all of the other pieces together, that I had the right ordering clinicians, and that I knew that I had a good documentation process for the physician. So connecting all of the dots, why I'm ordering these genes, and how does that relate to the clinical presentation of the client and the patient, and what will I do with those results once I get that information back. And I really think you're playing with fire to have an assay that doesn't have relationship to national accredited standards bodies like these that we've mentioned here, and then not realizing that a doctor that's ordering that test may not even be able to treat the patient for those conditions. And so it could be really scary to find out that, well, yeah, Medicare will pay for these tests, and that those tests might not really have medical necessity. And again, the common refrain that you will hear most labs espouse is, well, I'm not the clinician and I don't know that stuff. But here's the thing, you're the one who's going to get paid for them. And so that won't be an excuse when they want to come back and take the money back. And then let's layer on top of that, that we threw in some telemedicine, and now you could be in some real trouble that those samples that were ordered may have been acquired in a manner that also violates Stark or ECRA, or maybe a kickback is involved in there and you're not even aware of that because it's happening at another level. So if you're going to do these bigger tests, they're going to be looked at and scrutinized a lot more. You'd want to make sure that you had an assay that had relationships with nationally recognized bodies that say these things do need to be tested and they have these clinical utility. And then you're going to want to build your medical necessity documentation around that, that your requisition has everything in it that you need, that you have the right diagnostic codes, that you have the right precursor tests that you might have needed to do before that. You would want to make sure that your result reporting is accurate and is within the bounds of what's going to happen to us when the FDA starts taking over, looking at all your LDTs. Like similar to the problem that we've had with PGX and the recent exodus. Well, they haven't exited yet, but in December, Translational will be exiting the market, and that has a lot to do with their report and what it's telling a doctor to do. There are restrictions about how you do that. So you definitely want to have somebody that's very, very well versed in this, a geneticist and also an MD, if you can find that rolled into one. There's not many of them out there, or you need to have several people kind of come together to build this for you, so that you're testing the right assay, you're recording the right information, and you've got that for you when you actually send out your bill. And the appropriate way to bill something like this is with an unlisted code. So they are going to ask you for documentation. If you're working with people that are stacking codes, meaning multiple codes going down on a big NGS test like this, you probably want to get that looked at heavily from a coding perspective. And then, you'd have to do all of your result reporting, and then you're going to want to make sure you have clinical support, meaning that maybe the clinician that helps you devise the panel along with your medical director to be able to support the physicians when they ask you questions about the result report. All of that being done would be very helpful. So something that an immunology panel really should look like, instead of some collection of 500 genes and then somebody slaps the words immunology panel on the top and they're looking at BRCA1 and 2, which are meant for cancer and have no relationship to an immunodeficiency, would not be good, right? So you would want to see that you'd have a series of genes, that being your assay, the genetic content, and then you'd have your primary medical indications, and then underneath of that, you'd have your symptomatic relationships. And you can see here, I only put this up here not to try to tell you how to build this particular panel, but that there are different kinds of immunodeficiencies, just like there are different kinds of neurological disorders. There's Parkinson's, Alzheimer's, dementia. They used to call it that, PAD, and now they call it DAP. But those are actually not the only ways to look at a neurological disorder. And similarly with an immunodeficiency, you can have different things that are related to, like how somebody will respond to a viral infection. You can actually have immunodeficiencies related to viral infections. And half of this stuff, I don't even know how to pronounce it, but these are different things. And that's what I'm saying is you'd have to really find the right doctors to order this, that even understand what the name of the panel is, let alone what these genes mean and how they have a relationship to diagnosing a patient and then figuring out what you need to do with them. But if you invest that time in doing it, if you want to know what's next, this is what is next. So anyways, that comes up a lot for me. And then there's histology and cytology, and there's urine drug testing, and there's a lot more testing out there available for everybody to do. Really, what you should look at it in my book is, what do your providers want? And then go do that for them. And they will stick with you if you try to only pick the du jour of the day when that price comes down, or when people start saying it's experimental investigational, or when it becomes out of vogue, then your whole cost structure will change and your profitability will go down. But developing solid relationships with your physicians and serving them, they will be loyal to you. Let's see. Okay, so payer mix. Okay, so this is another really important evaluation when you're thinking about taking on a referring physician. So first, let me give a little bit of commercials, Medicare, and Medicaids and how they work. So with commercials, most plans that most patients will have some concept of out-of-network benefits. So just because I'm not in network with a Blue Cross or a Cigna or an Aetna or a United doesn't mean I won't be paid. What it does mean, though, is the allowable you will get. And let me preface what that word means there. So there's what you bill, your bill charge. You could bill $1 million for something. No payer cares, right? The only time it matters what dollar amount you billed is if you build a dollar amount lower than what their allowable is, they'll pay you less, right? But they all have an ultimate allowable amount. And if your price is over that, it's just a contractual obligation write-off. Even though you don't have a contract, that's what they call it, right? But that difference between your bill charge and what they allow is kind of what they were talking about with the No Surprise Billing Act, that most labs that I work with would never even have tried to bill that anyways. But that difference is not something that you're billing to the patient unless you have an advanced beneficiary notice and you've told the patient up front, you're not going to be trying to collect that money from a patient. So then you have what they allow. When you're out of network, that allowable is going to be higher than what your in-network allowable is. And that's really what getting a contract with a payer means at the core of it. When you get an in-network contract, what you get is a lower dollar amount for the services that you provide. But what also happens, though, is when you're in network, or I think most people are familiar with their own insurance, that when you go in network, that means your deductible is smaller, your co-insurance is smaller, your copay is smaller, or maybe doesn't even exist, right? But if you go out of network, well, you've got usually double your deductible, if not more, and double your co-insurance, if not more. And so that has a big impact on you and your patients. So even though you may have billed $200 for something, and the in-network allowable for that is $100, but the out-of-network deductible is $150, here's what could happen to you. That in-network patient, maybe they've satisfied all of their deductible, and they've only got a 20/80 co-insurance. Well, you're going to get $80 out of that $100 now. But in that out-of-network scenario, they said, yeah, we would pay you $150, except you know what? The patient still has a $5,000 out-of-network deductible. So you still get a big goose egg, right? And now you also have a bigger bill going to your patient. And that's a problem for penetration of the market to your providers, because that's usually what they're going to ask you. Are you in network or not? And the reason they're asking you that is because they want a smaller bill going to their patient, because they don't like hearing about their patient coming to them and complaining, why are you sending to this lab? They're out of network, and look at how big my bill is, right? And then that pushes labs into scenarios where they start considering not making a good faith effort to collect that money from their patients, which you need to do. And it's not just a federal law, right? Routine waiver of copay and deductible. There's federal, there's state level rules about this, but even more, it's also constitutes a fraudulent claim. Because if you're saying that your price is not your price, you'll charge, and that you aren't going to collect that money and you're okay to take only what insurance would take, then you misrepresented what your fee is. And so they can then come back and say they don't owe you any money. So you do have to make a good faith effort to collect. A lot of people equate that with sending 3 statements. There, as far as I'm aware, and you would want to talk to your lawyers about this, there's no definition of what good faith effort means. But obviously, if you never collect any of it, you probably didn't make a good faith effort, right? But there's no rule that says you have to send your patients to collections. You are not a collection agency. Your billing company doesn't even operate as a true collection agency. They're not going to send people to, ruin people's credit, right? But there's nothing wrong with you asking for the money that's owed to you by exactly what the EOB dictated. And that's another thing too, is this isn't your fault. This is what the insurance company did to this patient. They moved it all to their responsibility, even though the patient's paying money. Now, the other thing to understand about commercials is there's 2 big differences, right? There's the blues, which there are 1 for each state. And to be contracted with them, you have to do them all individually. There are some programs like Blue Card, which cover multiple states, and then there's Anthem, which covers multiple states. But for the most part, you're going to individually contract with them. And they can also have different policies between them about whether they do or don't pay for things. And the other unique thing about Blue Cross Blue Shield, kind of like a Medicaid, you have to send it to the state, well, where the sample was collected. So Blue Cross has this weird rule about ancillaries, which laboratories are considered an ancillary. And so they make us send the bill, in most instances, to the state where the sample was collected, which is kind of like a Medicaid, right? You always bill to, if somebody had Florida Medicaid, you bill Florida Medicaid. You don't bill your home state Medicaid, which is kind of the reverse for Medicare, right? It doesn't matter where the sample is coming from. You bill the Medicare for the region you are in. And then the other things that happen with Medicaid that usually confuse people is a lot of the time, I think it's somewhere between 50 and 80% of anybody on a Medicaid is moved to an MCO, which is a managed care organization, which are typically done by the commercial payers that we're aware of, right? United has stuff called United Community, for example. That's an HMO, though. But you will see that the Medicaids, the patient isn't actually on straight Medicaid. So a couple of problems will accrue for you. Since that changes over time, and if the referring physicians aren't asking every time the patient comes in like they should for their insurance card, and then confirming and verifying their insurance, they might tell you they're on Texas Medicaid, but they're not. They're actually on Superior. And if you're not credentialed with Superior, then you're not going to get paid. So this is the problem that we run into as labs that, well, number one, it's a lot of credentialing to credential, 20 or 30 states, just even to get to the state level Medicaid. And there's whole bunch of problems with credentialing with Medicaids. Sometimes certainly you would always want to have your own home state Medicaid, and that's typically a predicate for any other out-of-state Medicaid that you're going to try to credential with. But on top of that, there are some states that require that you already have a claim for them. And then there are some states now that don't retro. And then there are some states that absolutely demand that you have a brick and mortar lab in their state. Like I'm having a lot of trouble with Medicaid of Nevada right now for somebody because of that. So Medicaids can be a little tricky, but the real tricky part is that, your patient's probably not on the state Medicaid anyways. They're probably on an MCO. And there are hundreds of MCOs. I mean, every state has at least 3 or 4. And you go to California, and I think there's 100 of them. So it's really, you got to really pick your battles and know where your referring physicians reside and go after those locations. And so let's see. And the other thing that you need to think about now with United is if we're talking about the DNA, RNA type tests, any molecular pathology testing, you're going to need Z codes and technical assessments. Although my little birdies are telling me that people aren't getting denied for that yet, it clearly is in their policy, and I'll show you some of the CPT codes that are related to that next. Probably should have had this slide a little earlier. These are all the MCOs, and I was trying to explain that to everybody. Not an MCO. These are the MACs, the Medicare Administrative Contractors. So Novitas, First Coast, and NGS over here, and over here, non-Moldex, everybody else, Moldex. No, Novitas is over here too. What you've got with UHC that you need to be paying attention to is they're on wave 1 right now, and this is actually a little bit out of date. The link here is it's still on their link. But they do have some 87 codes, which are going to impact us on the infectious disease. But it looked like to me it was only like for RPP and GIP, the bundled codes. They didn't have all of the little individual codes. So I think that might be why some people are saying they're still kind of getting paid for a UTI, because that would be billed with a bunch of these little individual codes that they haven't put on the schedule yet for having a Z code. But certainly, our main codes, 225, 226, 227 here, those are PGX. If you're doing PGX, they should be asking you for Z codes, and eventually they will. And who's to say they won't come back and say, I told you you needed to have one, but you didn't, so I want my money back. So start thinking about getting your Z codes for PGX, which, by the way, is not the same kind of problem that you have with infectious disease. You can certainly, you won't have the showstopper of clinical utility. In fact, the technical assessment for PGX does not even have a tab for clinical utility because it's so well defined in the LCD. In fact, if you kind of take a look across the spectrum of the Medicare administrative contractors for PGX, you can kind of see, like here, this is whether it was CPIC level A or B, or here it was whether it was the therapeutic recommendation by FDA table 1 or 2. You can see sometimes I do have stuff on the CPIC level B, but it's not actually even in the LCD. And so depending on what MAC you're talking about, you would or wouldn't consider trying to bill that, because the Moldex MACs, when I spoke with them, indicated to me that if it's not on their LCD, then they don't want to be paying for it. But it kind of does say in the LCD, if it is CPIC level A or B, they're going to cover it. But then they do give you a very specific table and tell you exactly what you're going to do. And it's interesting too that, you know, sometimes Novitas will cover something, but the others in Moldex don't. But it's almost a moot point with Moldex, because you're going to get a Z code for a panel with them most of the time anyways. And, you know, you could still be setting it up. It's just they wouldn't individually support medical necessity by themselves. But there are quite a number of combinations of gene drug combinations out there that are available. And you just kind of have to work with somebody who's going to be able to pay attention to it for you about which ones your MAC is going to pay for. And commercially speaking, we are starting to get more traction, particularly with the new biomarker laws that are coming out there. While they weren't the biggest ray of sunshine that I thought they were going to be, it does seem that the payers are a little bit concerned on one of the elements of coverage, which would somewhat indicate that if you did have a Z code in a technical assessment, that you could probably use your biomarker laws for doing it. And, you know, I might be able to do a good webinar for us on biomarkers and kind of drill down into all the different states and what it means. But in general, you can understand this, that the definition of a biomarker is very broad. But when they talk about the testing, it does look to me like they're saying multi-analyte. They're talking about whole genome sequencing. They're talking about testing methodologies that would be appropriate for looking for DNA and RNA. So these biomarker laws are going to be able to help us with PGX, perhaps even infectious disease. And it's basically several categories of it. Like if it's an FDA approved test, we're probably going to be able to use these biomarker laws to get payment. If it has an NCD, which of course PGX doesn't have it, but there are some cancer testing that have national coverage determinations, then they're supposed to pay for it under these biomarker coverage laws. And then there are indications that if there are nationally recognized clinical protocols for this, then we should be able to use those. It's going to be a lot of work, and they're going to evolve over time, and not all of them say it exactly the same way. So there's a lot of inconsistency, but for states of your interest, you should definitely start paying attention to and understanding the biomarker laws related to that. I know we only have 2 minutes left. In general, with Medicare for PGX, in a Moldex state, assuming you have your Z code in your technical assessment, the ordering burden requirements on your ordering physicians are greatly reduced because you don't have a specific set of diagnostic codes that need to be matched with the CPT codes that you're billing. Whereas in a Moldex MAC, I'm not saying you don't need a diagnostic code. You do, but they're not going to look at that diagnostic code against another list of diagnostic codes to see if it's one that fits in that list. As long as it's a diagnostic code that has a relationship with why they're ordering the medication for the patient, you're going to be fine. Urine drug testing, many of the LCDs have been updated recently. I think the biggest thing that I'm running into is people not having a risk assessment score for chronic opioid therapy patients. And when you get asked for medical records, when you've exceeded more than 12 tests in a year, they're going to want to see additional documentation for why you've exceeded that. And if the patient isn't listed and you don't have one, they might even go back and recoup money from you. So when you're doing chronic opioid therapy testing, which would be analogous to stating pain management, you want to make sure that you have a risk assessment score. And the LCD specifies the SAMHSA one, but it doesn't have to be that one. It could be whatever your doctor uses. And then based on that score, they should be following the dictated frequency. And I do believe frequency is the new way of looking at not paying for urine drug testing. Additionally, commercially wise, you need to be aware that when somebody's in a facility for substance use disorder, a a lot of commercial policies, Anthem being a big one, will indicate that kind of like Part A and Part B for a nursing home. When you do a nursing home and a patient's on Part A, you don't have anything to bill. You need to bill the nursing home directly. In the same manner, when a patient's at a facility for substance use disorder, the cost for incidentals like diagnostic testing are considered included in the rate that Anthem is paying to that facility. And so you're supposed to bill the facility for having performed the toxicology test. And because people have been erroneously billing the place of service, it slips by Anthem's edit. But then Anthem will later on do an audit against their patients. And if they were in a facility and then they paid for other ancillary services like a toxicology test, they come back and look for a recoupment. So I would definitely take a good look at that. Infectious disease. I think we kind of covered that a little bit. You know, you're just not going to get paid for it in a Moldex Mac for the most part right now. And yeah, I know I'm over the time limit. And NGS, we went into that in a lot of detail. I do believe the biomarker laws will help support us. Commercial policies vary wildly. In a Moldex Mac, the whole question about whether or not you're going to get paid for it is going to be sorted out for you when you do your Z code and your technical assessment. In a non-Moldex Mac, I highly encourage you to make sure you're doing the right assay, that you've got clinical utility, and you are on top of that and managing the utilization of that test by your ordering physicians, or you will be looking at recoupments. Last thing to say is develop relationships with labs that you can trust to send out samples to. You want to make sure that they can run the test the same way that you can run it, that their billing practices are similar, and that you can trust them not to steal your referring physicians. But once you can do that, find labs who are credentialed with these MCOs that you can't get paid for. You give them the sample, they run it, they bill it, you didn't experience the cost. This will increase your bottom line. Thank you for everyone for joining us today.
Thank you, William. Does anyone have any questions for William? Please feel free to raise your hand, or if there's anything that he needs to answer. William, it doesn't look like you have any questions. Just to do a recap, if you can please fill out the survey so we know, what type of topics you'd like us to do a webinar on. Also, as a reminder, we will be sending out an email with the slide deck as well as the recording. And with that, thank you so much for everyone for attending today's webinar. And William, thank you so much for presenting.
Thank you. Bye.
Bye-bye, everyone.